Hey everybody. Had a follow-up call with a patient this morning. He's 3 months post PRP injection for some chronic right foot pain that he's been having. And this patient unfortunately falls in the non-responder group. And I wanted to use this opportunity to talk about this because it may be important for you guys out there if you go through and have a regenerative injection or any other type of injection therapy and you don't have a response. What my clinical thinking is, in moving forward with figuring out what's the next steps, where do we go from here, what does this mean? And I don't get to talk about this a lot. One, because thankfully my non-responder rate is pretty low, which I don't know why. I could just be that the patients that are walking in to my clinic are good candidates for the therapy. It could also be because the thorough physical exam and history that I take and my meticulousness in regards to the actual injections. I have a feeling it's probably both of these. But that being said, I think it's really important to talk about these failures and to call them as they are, a failure, because it allows us to get better. Because if we don't focus on what we can learn from a failure like this, then we're missing out on a huge piece of the learning curve. So this patient, our physical exam initially was pretty unremarkable in the sense that there wasn't a lot of orthopedic testing that we could do that recreated his pain. Now, we had some MRI findings that we incorporated in with our treatment protocol in terms of what we treated. But my initial diagnosis on what was going on was basically a prior injury to the spring ligament in the foot. Spring ligament's an important ligament that helps to maintain the arch. And when we go under load, meaning when we're walking, that spring ligament is going to stretch a little bit, and then it provides some of the recoil to the arch that allows us to be more efficient with our movement. And so there were also a few other of the deep interosseous ligaments and things like that I thought might be involved just based on palpation where he was hurting, but also just based on where he was having pain. And so we did a pretty thorough treatment, treated subtalar joint, treated the talocrural joint, and about 4 or 5 various ligaments in the foot. And so in him coming back and saying that, he got worse for about 4 days afterwards, which is pretty common post-procedure. But then he, hasn't seen an improvement in his symptoms in 3 months. A few things run through my head. The first one, and this is not specific to this patient, this is just one of the things that I think through is there a condition that may predispose a particular patient to a non-healing state or to a slow healing state? Things like that could be androgen deficiencies, so testosterone or DHEA, or growth hormone and IGF-1. Is it a metabolic condition, something like hyperinsulinemia and high glucose, hyperglycemia, because we know that on the extreme end of those patients, they don't heal their tissues as well, just because of the elevated glucose levels, and that's why you see diabetic ulcers and things like that. And so, I think about those comorbidities in terms of impairing the healing response. And frankly, this patient lives a pretty healthy lifestyle. He's very health conscious. He actually works in the healthcare field, and so I don't think that's contributing to it. So then the two other things that I think of are, did we miss something in the diagnosis? So as an example, if we suspected it was the spring ligament and we appropriately treated the spring ligament, if it was actually like the talocalcaneal ligament, and it was one of the deeper portions that, it could be roughly in the same area, or at least on palpation, could mask itself as spring ligament, then that's a potential thing that we missed, right? Because if we treat the spring ligament, but is really a different ligament that was contributing to his pain, then we're not going to get a response because we didn't treat the pain generator. Or one of the other things is if we have a nerve entrapment somewhere in the foot that's contributing to the pain, and that gets masked and looks like a ligament injury, and we just treat the ligament. Meanwhile, when we do treat ligaments, the nerves in the area are going to get bathed and they're going to get some treatment. But if there's a really specific spot where there's a fascial entrapment of the nerve and that wasn't treated, then there again is a misdiagnosis on that. And the other thing with the foot that we have to consider is potentially some fat pad atrophy. And so while not overly common at someone his age, because he's under 40, and so it's not as common in that, but that could be a contributing factor, because if we even if we treated the right structures, if he's constantly doesn't have that cushioning from the fat pad, then we might see a lack of a healing response, because every step he takes, he's just in a chronic non-healing state because he's applying so much pressure and he don't have the cushioning of the fat pad. And then on the other side of the equation, we have the idea that, okay, let's say we have the diagnosis correct. Let's say it was the spring ligament. Then the why a patient may not respond is the needle, or my needle, didn't actually go into the spring ligament. And that's something you always have to think about. Whether you're doing, you usually have to think about it more so when you're doing palpation guided, so basically non-imaging injections. And you have to think about it less when you're doing imaging guided injections, but you still always have to think about that. And I went back and reviewed the images from the injection, and the needle got into all the areas that I had determined I wanted to treat. And so in his particular case, I don't think that's the issue. And so stepping back to look at this case and really asking myself, what did I miss? What could I have done differently and done better? I think it comes down to that I missed something in that diagnosis. And so we didn't get to treat his pain generator because I was incorrect on where his pain generator was. Anyone who's worked with me, whether as a student or as a patient or anything like that, understands how thorough I am in my history, my physical exam and assessment. And so it is difficult when these cases happen to me, because they don't happen often, which I think makes them more difficult, just because I don't have to deal with the emotions that occur, when I was incorrect. But unfortunately, that is part of medicine, and that is part of this area of medicine where we're doing things against standard of care. Right? It's not standard of care to get a PRP injection for foot pain. So that's, I'm kind of rambling at this point now, but so my plan with this patient is to get him back in the office. We are going to repeat a physical exam from head to toe again. I'm going to look at other areas of the body that might be contributing to predisposing the foot to be at a position where it's painful, because if those need to be treated, then we can incorporate that. And then I will likely do a diagnostic injection to see, with lidocaine, to see if I can resolve, temporarily obviously, improve or resolve that pain that he has, because that will allow me to, when we go in with a regenerative therapy, to be more confident in that what we're going to be doing is going to be beneficial. Because if I go in and I put lidocaine in or around a particular structure, and we're specific on that, and we see an improvement in the pain, then we know at least we're dealing with the actual tissue that is contributing to pain. Because again, the most extreme example is if your knee hurts and you put lidocaine in your shoulder, it's not going to make your knee better, right? And so a more localized answer or response to that is, if we put lidocaine around the spring ligament, but it's actually a nerve that's trapped, and that lidocaine doesn't actually contact the nerve, then there'll be no change in the pain. Whereas if we suspect it's a nerve entrapment and we put lidocaine around that nerve, that will temporarily make the pain go away. It'll obviously come back because lidocaine wears off, but it at least tells us that, hey, that was our diagnostic injection that shows us this is the area we need to treat, and then we can move forward with our regenerative injection therapy and hopefully help this gentleman out. All right, everybody, I hope you appreciated, just this clinical thinking that I have on the reality, when cases don't always go that well. All right, see you later.